tell you everything that you need to know for the test. So does anyone need any clarification before we start? All right, so let's review. Nutritional assessment from a laboratory standpoint, biochemical markers are pretty significant, especially whenever you're evaluating a patient's protein status. So as you'll remember, the three main ones that we can look at are albumin, prealbumin, and CRP. And prealbumin and CRP are the ones that we'll look at most often, especially in acutely ill patients. And we'll go over some of the reminders for the reasoning for that on a later slide. From a normal value standpoint, I've got those normal values listed here, albumin being 3.5 to 5, and the mild, moderate, and severe are of course listed there. And then prealbumin is 15 to 30 milligrams per deciliter, and you'll note the units are different. So albumin is 3.5 to 5 grams per deciliter, and prealbumin milligrams. Whenever we're selecting the way we want to feed a patient, enteral should always be ruled out before we move to parenteral. So we should assume that we can do enteral until proven otherwise. It's more advantageous because it's more physiologic. So it maintains the gut integrity and prevents atrophy. It helps preserve immune function because IgA is produced in your gut. And there's less infection risk. You don't need a central line, and obviously it's less expensive because TPN's expensive. So remember the mantra, if the gut works, use it. You have NG and OG tubes, which are short-term delivery. You can do the surgical placement, which is a gastrostomy or a jejunostomy tube. There are different advantages and disadvantages to doing these. So I just alluded to one of them. NG and OG tubes, or nasogastric and orogastric, as well as NJ and OJ, are more short-term use. The jejunal placement is more difficult to do. It takes a little bit more practice, and it can come out of place more easily. However, the jejunal placement does have a lower aspiration risk. Any placement of a tube in the stomach is going to increase your risk of aspiration if you don't have good gut function. And either of those types, NJ, OJ, or NG, OG, have the risk of infection. Specifically, the nasal placement has the risk of sinusitis. Any placement in the jejunum, whether that be the jejunostomy or the NJ, OJ, also can decrease your tolerance, so you have to feed a little bit slower and more gently. You can't do intermittent or bolus feedings. Gastrostomy and jejunostomy also tend to be smaller, so it's more difficult to give meds through those, especially if you're crushing meds and you have the risk of clogging the tube. And then jejunostomy more so than gastrostomy on those. So you can see advantages and disadvantages there. I didn't list all of them, but those are most of the clinically relevant ones that we consider in daily practice. When you're considering specific disease states and formulations for nutrition, there's some that are relevant and useful in clinical practice, and there's some that you might hear referenced in the future that are not so clinically relevant or have been disproven. When patients have renal disease, you want high density of calories as well as low electrolyte content, and that's not the calorie density itself that matters, but just removing fluid or minimizing the amount of fluid administration that you give. And then the low electrolyte content, specifically potassium and phosphorus, those are high risk if they accumulate and they are renally eliminated. In patients with liver disease, it is thought that a higher amount of branch chain amino acids as opposed to aromatic amino acids may help reduce hepatic encephalopathy. This is somewhat controversial, but you may hear it referenced and should at least be familiar with the concept, whether or not you determine that it's true. In patients with acute lung injury or acute respiratory distress syndrome, any sort of lung pathology, it has been said before that a high-fat, low-carb diet is preferred, and that's because it was thought that lower CO2 production occurred with a higher fat diet, but ultimately, if you're using energy at all, you're producing CO2. And so really what you want to do is avoid overfeeding the patient, period. So the carbohydrate is less significant than just the total calorie count. And again, anti-inflammatory, antioxidant-containing formulations may be helpful, but again, it's somewhat controversial. And then for diabetic patients, this is somewhat more intuitive. The low-carb formulations are preferred, and high-fat being just because that's the only other way to provide calories other than protein. As a reminder, these are your body fluid content, so if you have significant loss from these areas, then you have to consider that in your TPN formulations. The ones that I want you to be most familiar with are the gastric loss, so that could be vomiting or NG, OJ tube output. I think that is significant for one of your cases. This can cause a metabolic alkalosis if you have a high amount of gastric output, and it's typically been described because of your loss of hydrogen ions, so you're losing acid and causing an alkalosis. It really has more to do with your chloride loss and your body trying to maintain electronegativity, so the bicarb has to go up to compensate for chloride loss, but the hydrogen ion is an intuitive explanation, so if that helps you remember that, then that's okay. Pancreatic, biliary fistulas, diarrhea, any of that sort of lower GI fluid loss, the primary thing that you're losing is bicarbonate, so that can also cause an acid-base disorder. In this case, it would be a metabolic acidosis because of direct bicarbonate loss. And then diarrhea specifically also has high potassium content in it. So again, this is relevant because it helps you determine what your electrolyte content is in your TPN if you have noted that you have a pretty significant loss from any of these areas. From a monitoring standpoint, you can read the slide. It's important to monitor ins and outs, so total amount of fluid going in versus total amount of fluid going out. Remembering that you will have some degree of insensible losses, and that will be higher if the patient is febrile, if the patient has a high respiratory rate, but it's not uncommon for patients to have up to 1 liter or more of insensible losses per day. So that could be an explanation for an imbalance between ins and outs. From a laboratory standpoint, there are several electrolytes that you need to monitor. You should monitor renal function, glucose, liver function tests, and so on and so forth. So a variety of things that you can monitor. You may also note whenever you get into your 4th year and on into clinical practice that sometimes the ins and outs, unless you calculate them yourself, are not totally accurate. So if you can get daily weights on a patient, usually acute changes in a patient's weight are not due to nutrition or due to fat storage or anything like that. Usually those rapid changes in weight are due to fluid loss or fluid gain. The limitations to enteral nutrition are important to know as well. Like I said, assume you're going to do enteral until you can prove otherwise. So if you're going to take hold of that idea, you have to know what the limitations are. So one, if the intestines, the stomach, if it's just not working. If it is working, but at a limited rate, or they have extremely high nutrition needs and you can't meet those through enteral nutrition alone, then obviously that's a limitation where you might have to look to TPN. Shock patients, it's really not a great idea to do enteral nutrition, especially in the first few days of these patients' hospital stay, because there's reduced blood flow to that area. And so you not only reduce the intestinal functioning, and you probably have pretty low absorption because it's not getting high blood flow, but you may actually worsen the situation by causing intestinal ischemia, small bowel obstructions, and things like that. Other absorption problems like short gut syndrome, or any other pathology like inflammatory bowel diseases that are significant or in an acute flare would be limitations to enteral nutrition. And then finally, if the patient just won't do it, if they're not conscious enough or you're not confident enough in their ability to swallow because of altered mental status, but they refuse tube placement, obviously your only option then would be parental nutrition. As pharmacists, as I said before, we have to consider medication issues with enteral nutrition. You're probably crushing your meds, so most extended release formulations cannot be crushed. There are some that you're able to mix, and then capsules can go, some of the beads can go in liquids, but it's very drug specific. You also have to consider the precipitation of these drugs as well as nutrient interactions, so important ones to know, and again, like I said before, this is important for your test. You have to know drug and nutrient interactions, and know not only that, but how do you fed. So if there is an interaction, not only be aware of that, but how can you resolve the interaction? And so fluoroquinolones, tetracyclines, warfarin PPIs, and then phenytoin. And generally, a good rule of thumb to resolve this is to hold your tube feeds for 2 hours, administer the medication, hold for another 2 hours, and then resume. So you can see how if you can get around that, obviously it's very helpful, because not only does the nurse have to remember to hold for 2 hours, but you also have to adjust your rate of nutrition to make sure that they're getting the same amount that they would get if it was able to run continuously. And giving medications multiple times a day only compounds that issue. So we've kind of gone over these already. What are your indications for parenteral nutrition? Your gut's not working, the patient has cancer, and so they have high nutritional needs, or else they're undergoing radiation, and so part of their gut may not be functioning appropriately, or they may have severe nausea and vomiting. In pancreatitis, it is possible to feed a patient, but you have to place a jejunal tube, and it has to go beyond the ligament of Treitz, which is more of a fun fact. You don't have to know that, but just be aware it's possible to feed a patient with severe pancreatitis, but not generally recommended to do so generally. Again, critically ill patients, especially who are in shock, patients whose gut is not working because of nausea and vomiting, or if they have eating disorders. It's good to know these complications as well. They are pretty significant. Most of them, I think, are intuitive. So hyperglycemia because of excess glucose delivery, especially in diabetic patients. Increased triglycerides because of excess lipid administration. Infection, and that can be sinusitis with a nasal feeding tube, or it can be catheter associated with parenteral nutrition. And generally, if you see an infection with parenteral nutrition, it's going to be a fungal infection if it is something that came from the TPN itself, simply because that's the only thing that can really survive the high osmolality of the TPN. Refeeding syndrome is important to be aware of. So your body, when it's in starvation, has a deficit of electrolytes. In order to maintain normal serum electrolyte values, these move from the inside of the cell to the outside. When you're fed acutely, the insulin release and all of the other hormones that are released due to your feeding, especially if you're fed very rapidly, will cause the rush of these electrolytes back into the cell. So potassium, phosphorus, and magnesium will drop very acutely. That can cause life-threatening musculoskeletal problems, as well as cardiac issues, particularly with the potassium and magnesium. So ways to resolve this: one is anticipate it, so give your TPN slowly, and then preferentially you would bolus these electrolytes, because if you put them in your TPN and you over or undershoot, if you undershoot, you're going to have to bolus anyway. If you overshoot, you're going to have to stop the entire TPN. And after you get out of the acute phase of refeeding syndrome, you're really just going to have to change it back anyway. Liver enzyme elevation, is important to monitor these generally like a weekly basis, because it's a long-term, like a chronic TPN type side effect where overfeeding can cause hepatic issues and ultimately liver failure if it goes unnoticed. Then enteral-specific complications are exactly what you would expect it to be. GI side effects, gastric residuals, which I talked about a little bit in the recording, aspiration, and then tube occlusion, which can be either due to feeding or to medications. Specific complications of parenteral, again, we talked about this. Gut can atrophy and your immune function may decrease, because if you don't use it, you can lose it. The Harris-Benedict equation is important. It is used in clinical practice. It is one of many formulas that are used. It is, as you know, on your cases for today. It will not be on your cases on the test. I can't expect you to memorize the equation. I think that's very realistic. However, it is something I want you to be aware of, and you should know the other estimate that we discussed, which is 25 to 35 kcals per kilogram per day as an estimate. That will come up on the test. So again, total kcal requirements, and then know your protein requirements depending on their level of stress. It should be very obvious on the test what level of stress they are. ICU patients are generally in severe stress. Hospitalized patients who are not ICU patients are generally under moderate stress. That will be sufficient for you as long as you are aware of that. When using weight, this is something I hope that you should have come across before in other pharmacotherapy lectures or issues. So, use your ideal body weight as long as they are not obese. If they're obese, use adjusted. If they're underweight, use actual. And that's listed there on the slide. You should know the kilocalorie components of lipid emulsions. Propofol is a 10% lipid emulsion. It's important to know that. So 1.1 kcals per mil is the protein or the kilocalorie content of propofol. And people can be on pretty significant amounts of propofol, which is a sedative used commonly in critical care, especially in ventilated patients. This is something that we do have to calculate whenever we're determining a total calorie content, because obviously if you're on high doses of propofol, this can contribute significantly, up to 500 kcals or more per day of what a patient is receiving. You have to memorize this. You'll need to know this for the test. You'll need to know it for rotations. And if you go into any sort of clinical practice in which nutrition is involved, you'll have to know it for that too. So it's important to just go ahead and commit it to memory, and then if you forget it, at least it'll be easier to relearn later. So when you design a parental formula for the purposes of this class, and hopefully for the purposes of the rest of your life, generally central parenteral nutrition is preferred due to high osmolarity. It's almost impossible to adequately feed a patient with peripheral parenteral nutrition, and so we won't really be considering that. It is an option. It is not an option that I would recommend, and not an option that ought to be used routinely. So to that end, whenever a patient receives an order for parenteral nutrition, we have to make sure that they have a central line before we can actually start it. You also have to consider the patient's history. So what is their degree of illness? If we're doing our formula, we have to consider any of the multipliers that we might want to use. So sepsis, burns, if they're in the bed, not in the bed, all of those multipliers are relevant when it comes to past medical history. Calorie requirements, again, will be adjusted based on stress level, and then fluid requirements. Obviously, we have to know not only how much fluid do they need for the TPN, but as Dr. Hawkins may have mentioned to you yesterday, you get a significant amount of fluids from, or not yesterday, but last class, you get a significant amount of fluids from medications that are administered. So any IV medications, any drips that you give, it is a source of fluid, so that does have to be considered. And then electrolyte needs are important. So again, repeating syndrome being the main one, if you have significant fluid loss from any of those sites we mentioned before, or simply, do we already have an existing electrolyte disorder? So the point of this slide is not memorize the slide. The point is there are an enormous number of things that can affect your fluid requirements, and you do have to be sensitive to that and monitor appropriately. When calculating macronutrients, you want to, one, determine your total caloric needs, so that would be Harris-Benedict or your 25 to 35 kcals per kilogram estimate. Then determine the protein needs based on their stress level. You will subtract the kcals that they get from proteins from your total calorie needs, and that will give you your non-protein calories. Usually 30% of your non-protein calories are given as lipids, and 70% is given as dextrose. You can modify this, sometimes you do, patient preference, past medical history, things like that can affect your ratios. But if on the test you are asked to design a TPN and it is not specified what percent of your non-protein calories are what, assume 30% from lipids and 70% from dextrose. And it is very, very important that you know, if you need to practice, then by all means practice how to convert from grams of a specific macronutrient to kcals, to volume, to percentage. So remembering, for example, 30% is 30 grams per 100 mils, 20%, 20 grams per 100 mils, and so on. So, and that's what this slide delineates. So knowing how to answer the questions in these examples is important, relevant for life, relevant for the test. And then finally, as I mentioned before, fluid volume. If the TPN does not provide the total fluid requirements, then you can supplement with maintenance IV fluid if the patient's not already receiving them. Do remember that initiating parenteral nutrition is almost never an emergent intervention. So you have time to calculate your requirements. You have time to wait on a central line. Generally, you want to start it once the patient is stable, and as long as the patient was adequately provided with nutrition, they were healthy before they were admitted, parenteral nutrition can be delayed for up to 7 days in hospitalized patients. This is reduced if they have mild, moderate, severe nutritional deficiencies, but if they're healthy, they can last and be perfectly fine for a week without nutrition. Initial values that you should get: electrolytes, so your sodium, potassium, chloride, magnesium, phosphorus, calcium, prealbumin, renal function, glucose monitoring, checking their ins and outs, checking their daily weights, and knowing their medications that they're receiving as well, particularly anything that gives fluid and propofol, because that can, 1, affect triglycerides, and 2, provide calories. I mentioned this before, but prealbumin is the preferred protein for monitoring. Has a shorter half-life than albumin, so acutely you can check a baseline and then check after several days of nutrition to monitor for improvement in the patient's protein status. This is important to be aware of, but in acutely ill patients, especially if they have ongoing inflammatory processes, CRP may be elevated. So you have to check a baseline CRP with your prealbumin. If CRP is elevated, then that means protein synthesis is being shunted towards CRP, and so your prealbumin is irrelevant. It's not helpful. Because, like I said, your protein synthesis is being shunted into acute phase reactants, and so you can't really interpret prealbumin, which the normal values are set in patients without acute illness. Albumin, like it said on there, should not be used for monitoring. All right, so that is the overview. That is the material that I think it is important for you to know for the test. Does anyone have any questions, any clarifications, any confusions before we move on to the patient cases? Good? Okay, great. So, we have 3 cases. Case number 1, 45-year-old male in the ICU on mechanical ventilation due to septic shock from a ruptured diverticulitis. He had a surgical colostomy placement because he had colon resection due to the severity of his illness. There's no gas or stool in the colostomy bag since surgery 3 days ago, which is an indication that he doesn't have bowel function at the moment. TPN support has been requested. He has reported 10 kilogram weight loss over the last 2 to 3 weeks. So he has an unremarkable past medical history other than his most recent diverticulitis. High weight, he's febrile, tachycardic. He has 3,300 mils in, 3,600 mils out. He's a little hypertensive. And these are his labs. So the questions that you were asked is, 1, is TPN appropriate for this patient? So we'll do let's just start with group 1 in Athens. Do you think TPN is appropriate for this patient, and why?
We said yes because he's in shock.
Okay. Yes, because he's in shock. Let's see, group 18 in Augusta. Do you have anything to add to that?
I don't think he can absorb the nutrients in the GI tract because he had that full resection.
We said that he needed parenteral nutrition because his gut is not working and absorbing nutrients because of his as indicated by his colostomy bag.
Okay, good. 24 here in Savannah. Do you have anything to add to that?
We also listed that he's intubated, so he can't eat orally.
All right, so your second thing to assess is what other information, lab values, anything else related to the patient's current status or history or labs would you like to know before you start parenteral nutrition? So we'll do group 21. What do you think?
Would it be nice to get the pre-albumin value?
Okay, pre-albumin. Anything else to add to that?
Is CRP?
Okay, pre-albumin and CRP. Group 6 in Athens. Do you have anything to add? Lab values, patient information, anything you want to know other than what's been given to you, pre-albumin and CRP. I like those answers so far.
Maybe other labs like calcium, magnesium, phosphorus, trace elements.
Okay, good. How about 16 in Augusta? Anything else that you would like to add?
We would like to know the current medications and fluids that the patient's getting.
Okay, perfect. So, from this standpoint, we want to know, is it appropriate? And we said yes. In addition to everything that you said, which is correct, he's malnourished, which we have in the patient report that he had a 10-kilogram weight loss over the past 2 or 3 weeks. We also noted that he had no bowel function, as indicated by the fact that he had no gas or stool in the colostomy bag. And in addition to that, we mentioned that he's in shock, which is significant. Other info, we mentioned phosphate, magnesium. We should also, calcium, which is correct. Triglycerides are important to be aware of, so you want to get a baseline triglyceride level. You have to ask the question, does the patient have a central line for TPN administration? That's relevant. Because remember, if we're going to adequately feed the patient, we have to give it through a central line. Like I said, it's difficult, if not impossible, to adequately feed a patient through a peripheral line. Baseline pre-albumin as well as a CRP, I think, is completely appropriate. And then current medications as well as fluids that they're on, which is correct. So good job. And before we continue, let me add, we would not be doing this if I expected you to know every answer, so it's okay to say I don't know. I want you not to be scared to give your answer, but to learn something from this. Because I recognize that nutrition is very different from most other things in pharmacy school, and it can be very difficult even for practicing pharmacists. So, with that said, we will continue. The next question that was asked is, what is the stress level that this patient is experiencing? It's mild, moderate, or severe. So we'll do group 3 in Athens.
Severe stress because he's in the ICU and has septic shock.
Okay, perfect. Easy enough, right? He's in the ICU, it's severe stress. Question 4. What is this patient's ideal body weight? And what weight should you use for nutritional calculations? So we'll go to group 11.
So we calculated his ideal body weight as 68.4 kilograms, and the patient's actual weight is 73. So,
Okay, so what weight should you use for your calculations?
yeah, we just used ideal because he's not significantly above his ideal body weight, so we don't need to use adjusted.
Perfect. So we use ideal body weight in this patient. And finally, using the Harris-Benedict and the estimation formulas, I want you to calculate, or I wanted you to have calculated this patient's kilocalorie requirements. So we'll start with the Harris-Benedict calculations. We will do 25 for 25 here in Savannah. What did you get for his total kcal requirements using the Harris-Benedict version?
Can you use your mic? This is enough to speak. Can you please use your mic?
So our range, calculated range is 2243.06 to
What is he saying? Like 10 doesn't. Put all that in.
2616.9.
Okay, perfect. So about 2250 to about 2620, if we want to say. Let's do group 8 in Athens. What did you get for the 25 to 35 formula estimate?
Because that's not within it. 25.
The one's 26.
Can you like that or maybe I'll put it up here.
You said 2250 to
21,710 to 2,394.
Okay, good. So make sure we use the equation for males.
You have to multiply that.
Get our baseline, find the bed, and we have multipliers for sepsis. Sounds like you use, which is perfect. Make sure you use ideal body weight in this case. Make sure you convert his height to centimeters. And then, once again, ideal body weight for this. Sounds like you did that more or less. Number 6. What are the estimated caloric requirements for this patient?
Can someone ask him what value you're supposed to use
Correspond
for
this to
sepsis?
the
That's
ins
a
and
range.
outs that we described in the patient case. So we'll do group 23.
Huh?
Gives you a range in the table.
Yeah, so what number do you multiply?
He used it with both, he did it with both,
Oh.
I think.
Yeah.
He did 1.2 and 1.4, and that's why the result is a range.
Why is it minus? Oh, 1.2 to 1.
Yeah,
It's
it's
like-
two, he's
Got
putting
it.
in the range, he's not actually subtracting.
Got it.
It's not.
I got mine, yeah.
I would be other, yeah.
Oh no, it's not us though. Probably number 6. Thank you, McDonald.
2,052 to 2,394 meals per day.
Okay. And how does that compare with the output that we listed?
It's less than the output.
Right, not a trick question. It's less than the output. So the output is over a liter more than the fluid requirements that we calculated. So the purpose of this is we have to look at the patient, not just run the numbers, so to speak, in order to actually determine how we're going to treat the patient, in this case with fluids. The patient is losing fluid at a significantly higher rate than what our typical equation would take into account. So we must consider this, try and determine where that output is coming from, and then replace fluid with the appropriate amount of electrolytes at an appropriate rate in order to maintain normal fluid status. Now, the other thing is you have to consider the patient's status. If this were a heart failure patient and they had significant edema and we were diuresing them, obviously what we want is a negative fluid balance. In a critically ill patient with shock and hypotension, we don't want a high degree of fluid output without a corresponding amount of fluid administration. So in this case, everything you said is correct. And so we have to account for that whenever we're calculating the fluid requirements. In this case, it's easy because we just look at the number. But consider all of the intricate details of the patient in order to actually assess what their fluid requirements are. Good. Group 14 in Athens. Question 7 is formulate a simple TPN based on your calculations. And what I'm hoping that you calculated is their protein requirements, and then their non-protein kcals, how many kcals you want from lipids, how many kcals from dextrose. That's it. I don't need fluid, I don't need electrolytes, I don't need micronutrients.
Hey, I just wanted to check in. We have a couple of things calculated, but we were kind of confused with a couple of ways of calculating. Just from the slideshow wasn't quite clear. So we got, we can do obviously the protein requirement, and we can do, the total calories needed per day, but and the fluid requirements. But how do we synthesize all that together is kind of like the sort of block that we're at.
Okay, so we have already established that's a good question. It's important to know, and it can be a little overwhelming. So we've already determined the kcal requirements, right? So if we take somewhere in the middle of what we calculated with our Harris-Benedict equation, we get a round number, we can just use 2,400, which is what I did for simplicity. What did you calculate for the total protein requirements?
2,600.
So for total protein requirements, I think we got about 480 kilocalories a day once we do the conversion, using the 1.5 to 2 grams per kilogram per day, since placing severe stress.
Okay, so severe stress, so 1.5 to 2, and you picked a number somewhere in the middle, I'm assuming, how many grams per day that they require. So what did you get for grams of protein per day? You told me kilocalories.
Yeah, we just picked 120 grams, just like you said, somewhere in the middle, and then we used 4 kilocalories per gram for a total of 480 kilocalories from protein.
Okay, perfect. So we are on the same page. Severe stress, about a range, about a zone. So the next step would be to determine the number of non-protein kilocalories that this patient requires. So simply subtract total from protein kilocalories, and that gives our non-protein kilocalories. 2,400. I trust that everyone knows how to use the calculator. So 2,400 minus 480 gives us 1920. And then do we remember the percentages? So our other macronutrients, non-protein macronutrients, are lipids and dextrose. Remember the percentages that we use for each of those to assume, if you're not told what percentage to use?
What did you say?
Do you remember what percentages of dextrose and what percentages of lipids you use to calculate the kilocalories for each of those?
30 and 70?
30 and 70, good. 30% lipids, 70% dextrose. So again, simple math once you know the values. So 30% lipids gives 576 kilocalories. The remaining is dextrose, 70%, 1344. So perhaps the confusing part of that is considering how you get there. So what is the amount of dextrose in the stock fluid? What is the amount of lipids, emulsion, how many 10, 20, 30%? All of that information is information that I don't need you to worry about. It will be provided for you if you need to know it. But the most important thing is that you're able to calculate kilocalories at this point. Does that make sense?
Yes, thank you. It was just a little overwhelming.
Yeah, no problem. I totally get that. As hard as it may be to believe, I was sitting where you are 3 years ago. So, anyone on any campus have any questions about that?
Do we round to the tens place?
Yes, you can. This is all going to be an estimate anyway, based on what a reasonable, like you're not going to pull up 576.137 milliliters of a dextrose solution. So rounding is completely appropriate. On the test, it's going to be multiple choice. Remember that. So you will be given 4 answers, and you pick the one that is most reasonable, closest to what you get. So it will involve rounding and a lot of picking a number in the middle. It should not be difficult, I promise. As long as you have memorized how many kilocalories per gram of macronutrient, the approximate 30 to 70% split of lipids and dextrose, and you know the stress level protein requirements, you will be okay. Everyone good on that? So our next case is a 75-year-old female on the general medical floor who's been admitted for small bowel obstruction secondary to adhesions. Upon admission, she had an NG tube placed, which immediately returned 1.8 liters of bilious gastric secretion. So she has significant NG tube output. She's been vomiting intermittently for the past 2 weeks, which is additional gastric output, and has been unable to eat anything substantial. She has had an 8-kilogram weight loss secondary to all of this. You see she's got her past medical history listed there. You see her height, weight, laboratory values are listed for you, as well as labs I just said. A TPN formula has been selected for you. They are currently on piperacillin tazobactam, which is providing 400 milliliters of fluid per day. And you are asked, first, what is this patient's ideal body weight, and what weight should you use for nutritional calculations? So we will go to group 9 in Athens. Ideal body weight, and what weight should you use for calculations?
We got
56.5 kilograms, and we use the ideal body weight because the actual is less than 30% of the ideal.
Okay? Okay. So we use ideal. Or no, actual? Did you say actual or ideal? I'm sorry.
Ideal.
Ideal.
Okay, good. Sorry, I misheard. So the next question is to calculate, again, total kilocalorie requirements using both Harris Benedict and then the 25 to 35, compare the results for this patient who is estimated to be under moderate stress. So group 7, what did you get for the Harris Benedict equations?
$13.76.
Is that 1376? Yep, okay.
That's right.
Great. So group, thank you. So group 4, what did you get using the estimation formula?
We got 1,425 to 1,995 kilocalories per day.
Okay, perfect. So in this case, 1376, so we use the confined to bed multiplier, and we don't need to use any other multipliers. And using the estimation formula, we see that our estimate using the 25 to 35 is actually higher than what you would estimate using Harris Benedict. So as you can see, just using these two formulas alone, there's a lot of variation in the estimates, but that's exactly, they're just estimates. And there are an endless number of other formulas that people use depending on preference, training, so on and so forth. But the important thing is to remember these are formulas, they're helpful, but they are estimates. So the next question is the current formula, the TPM that has been started, appropriate for this particular patient? So you're evaluating the appropriateness of a TPM that has been already started. We'll go to group 20. Okay, why is it inappropriate?
She's getting too many calories. She's getting 2,500 calories right now.
Okay, good. So we calculated, hopefully you did this, calculated protein requirements is appropriate between 1.2 to 1.5. However, as you said, 25 kilocalories comes out to 44 kilocalories per kilogram per day, which is far too much. This is not an appropriate TPN formula for this patient. We are likely overfeeding them. And there are a number of side effects that come with that, as we have already discussed. So, is the TPN providing enough fluid for this patient? We will do group 22. Group 22, what do you think? Right amount of fluid, too much, too little?
Yes.
Okay, we've got a yes for right amount of fluid, I assume. Group 10, what do you think?
Is an HE gastric tube 1700? Is that what it's giving out? What's going there?
The patient's getting enough fluids, I think.
Okay. Group 26 in Savannah, what do y'all think?
This is like input is 2400, and that's what these two are. Our output is that. Yeah, but it's saying it's sort of 3000, and she gave a 3000 output. So she's only getting 2400 in, but giving 3000 out, so she needs like a little bit extra probably.
Can I interrupt and ask a question?
Yeah.
So like, based on what we calculated, I guess their like fluid levels are good, but if they're excreting more than that, like, what does that mean and what do we do about it?
Okay, so you've kind of caught on to the point surrounding the issue, right? You've calculated a fluid requirement. This is what I assumed. Did everyone who answered 22 and 10, did you calculate a fluid requirement of 2,000? Ish.
Yes.
Okay, is that what you're basing your answer on?
We think so.
Yes, okay, good. I just want to make sure we're on the same page, so I'm answering the right question. So now the question is, if they have an output of 3 liters, not 2 liters, what do you do with that? So the answer is, from a pharmacy perspective, you try to ensure, unless there's a reason to think otherwise, such as against CHF, renal disease, in which fluid can accumulate rapidly, or if you're trying to get rid of fluid, in which you have a different case, but in this case you're not trying to get rid of fluid. You want to maintain eubulimia. You want to maintain an appropriate amount of volume in the patient. Now, how do we manage that? From a holistic standpoint, we want to fix the reason why the patient is having so much fluid output, right? But from an acute standpoint, we give fluid. So we need to meet the amount of fluid that's being excreted with the amount of fluid that's going in. So in this case, what hopefully made you ask the question was you identified they're actually losing a lot more fluid than you would calculate based on the 30 to 35 milliliters per kilogram per day because of their vomiting and NG tube output. So we have to administer more fluid, whether that be with PPN or with additional maintenance IV fluids to ensure that the patient remains equilibrium. Does that answer your question? Or is it still confusing?
Yes, but what is NG tube output?
So when the patient has a significant amount of fluid sitting in their stomach, in this case they have a significant amount of gastric secretions, you place an NG tube and you can either administer enteral nutrition or medications through it, or you can do what they call putting it on suction, where you suction out all of the gastric output that's occurring. So because of this patient's small bowel obstruction, they have a significant amount of NG tube output, so they don't have normal gastric functioning. When we place the tube, we suction out about 1.8 liters of fluid that's just sitting there because of bilious secretions. Does that make sense? So,
Yes.
from a fluid administration standpoint, it's the equivalent of the patient losing fluid through vomiting. And so we want to replace that fluid and consider the side effects, so to speak, that can have. So that's not, I understand, you don't see that, so you don't know what it is, so thank you for asking the question. Does anyone need more clarification about that? Okay, let me use one.
So when you're trying to find a weight to calculate, do you always use admission weight?
Typically, unless you have reason to think it's inaccurate. So one, from a practical standpoint, weights can be inaccurate on admission. If you don't have beds on your ED or scales on your ED beds, then usually they just guess. Is that good practice? No. But if the patient is at a normal fluid volume, so not volume depleted, but not volume overloaded, then yes, you would prefer to use their admission weight. Any fluctuation from that is probably due to volume loss, and it doesn't reflect a significant change in their flow volume and distribution. Anyone else have?
I thought you can get metabolic acidosis when you lose chloride.
He said alkalosis.
I know, but I thought that we always learned like.
I have a question in Athens.
Okay.
So we want to increase her fluid volume to 3 liters.
That's right.
And I know we do ratios for like the non-protein, etc., but we're not changing that just because we're increasing the fluid requirement, right? The volume, right?
Correct. So obviously not a part of this particular question, but yes, if this were an actual patient, you would want to correct the kilocalorie that is being provided, but you would actually want to decrease it because we determined that they were receiving too much. So one way that you can do that is if you're not able to give the kilocalorie requirements in the amount of fluid that you calculated, like I said, you can add normal saline, half-normal saline, lactated ringers, some variation of some other maintenance fluid in order to compensate for your fluid loss and give that in addition to the PPN. So this would be just a maintenance IV fluid, not more TPN.
Thanks.
What's a big enough difference in inputs and outputs? Like, is a 100 ml difference worth giving them a 100 cc bag of the fluid, or is that negligible?
It depends. So if this is a short-term issue, it may be negligible. If this is a long-term issue, obviously, if that's truly their input and output, then that will accumulate into a significant issue. The other thing to consider from, again, practical standpoint, we're getting into like what's more complex than will be on your desk. But from a practical standpoint, sometimes patients will be receiving TPN and they're awake. So they may not have good bowel function enough to receive enteral nutrition, but they're still awake and aware enough of their own thirst response to sip on fluid. So a patient may be able to make up for the slight lack of fluid loss with their own intake. Does that answer your question? Anybody else?
So just to clarify, when the input is posted, that already considers the fluid from the antibiotic in that total?
Yes. Because they're getting it every 6 hours, so that's 400 total cc's a day. So, good question. And again, in the medical record, this should be calculated for you automatically whenever you're looking at real patients. But it's important to have sort of a reasonable idea of where they should be, because sometimes there are errors in the way that crosses over. These are all very good questions. Does anyone need any more clarification before we go on? Okay, good. We covered our fluid requirements. Again, the ins and outs are not quite matched, so what we discussed is TPN volume is inappropriate, we should add maintenance IV fluid. Because of this patient's excess NG output, I mentioned this earlier, so hopefully this is a give me question. But what acid-base disturbance is this patient at risk for? We'll do group 2.
Metabolic alkalosis due to the gastric acid loss?
Good. Metabolic alkalosis. So going back to this, gastric fluid output, you lose a fair amount of sodium, you lose a whole lot of chloride, and you lose hydrogen ions. So this results ultimately in a metabolic alkalosis. And then finally, on day 10, with the same patient, you get these labs, which you should compare to the patient's baseline labs. Which of these lab values is the most significant indicator of good nutritional progress? We'll go to group 22.
Prealbumin.
Remembering that we want to monitor the patient's protein status. They started out pretty abysmally from a protein standpoint, and now the prealbumin is in normal range. Because prealbumin has a shorter half-life, we use this as a good indicator of their acute changes in protein status. Okay. All right, so we're on the last case. BB is a 53-year-old female, admitted for a ruptured appendicitis. Status post appendectomy now with colostomy placement. And that was because the patient had severe peritonitis in addition to the appendicitis and the past medical history that's listed here. HBI. BB has been very sick for the past week without any significant PO intake. The reason for severe problems is procrastination. Didn't want to come to the emergency department to get treated. And given this period of time elapsed without significant intake, the surgeon has requested TPN. So once again, we've got baseline lab values. We have TPN formula that's been calculated for you and has been already initiated. Just to point out to you, remember I said typical dextrose to lipids is 70 to 30 of your non-protein calories. However, this patient has diabetes, so that is likely the reason that we have elected to do 60% of dextrose instead of 70% of dextrose. Meds are listed here. The TPN was started as follows. We've got all of these labs listed here, same as on your case. As the consulting pharmacist, you are asked to address each of the following. So, once again, please do your best to answer the question, and hopefully we will have a good and helpful discussion about determining what is relevant and what is not relevant to address the TPN. So, with that said, let's start with group 13. What do you think about the patient's triglycerides, and how would you like to address it?
So we think the triglycerides might be too high because they were elevated from baseline.
Okay.
From 300 to 330. A bit elevated, but.
Okay. So at baseline, they're elevated at 300, and now they're at 330. So how would you like to address that?
Could we decrease the lipid content back down to 30 instead of 40%?
Okay, all right, I like the thought. We will partially answer that now, and then we will partially answer that in the other questions. So one thing to consider is the patient's triglycerides are elevated at baseline. So we should be cautious administering lipids, but if we evaluate what the patient has presented, they've gone more or less a week that we know of without food, and so their triglycerides were already elevated. Probably not due to their diet if they were going a week without food. So most likely the patient's triglycerides are elevated, one, secondary to starvation, and two, hyperglycemia can also cause elevations in your triglycerides. And so in this particular case, like I said, I like where you're thinking. However, we've got explanations for the triglycerides, and they're likely to actually decrease as we feed the patient, because they will move out of the starvation state and into a properly fed state where they can resume using glucose again. All right? Anyone have any questions about that? Hopefully that makes sense. So we will go to group 26 here in Savannah. How would you like to, what do you think of the blood glucose? How would you address it?
Patient's blood glucose is high and has been high since admission. We'd like to add insulin.
Okay, perfect. Does anyone in that group, we'll say with that group, have an estimate of how much insulin you would like to add? Anyone like that? Seeing a lot of no's. That's okay. I didn't tell you. So it is increased with TPN initiation. The patient is diabetic, we know that. So it is appropriate to add insulin to the TPN. Empirically for diabetes, one good estimate that you can use is 1 unit per 10 grams of dextrose that you're administering. This is good to know for life. You do not have to know it for the test. But I think it is, again, an important thing for you to have this information available to you, whether you memorize it now or you have to refer back to it later. From an electrolyte standpoint, consider baseline and now, and let me know what you think is going on with the electrolytes group 15 and what you would like to do about it.
The magnesium and phosphate are low.
Okay. And do you have a potential explanation for that?
Oh my god.
What was that?
He won't really know the exact reason. We're going to go ahead and say that because he's malnourished.
Oh, malnourished. Okay, that's part of the answer. Can anyone help us out? Anyone give a name to this? What was that? Okay, so the electrolytes, we have had pointed out that the magnesium and phosphorus are low, and I'll also point out that the potassium is dropping acutely from baseline. Can anyone give us a potential explanation for that?
Refeeding syndrome?
Refeeding syndrome. Love it. So how would we want to manage that?
Probably why you love it. Bro, you make me fall. Jesus Christ.
Do the bolus and electrolytes.
We have a bolus of electrolytes, right? So we discussed your two options for electrolytes, right? You put it in the TPN or you give boluses. Boluses are not, TPN is not a good idea because this is an acute issue that will resolve relatively quickly, and you can control it a lot more with boluses. So 1 week history of starvation, acute drop in magnesium, phosphorus, and potassium is very consistent with repeating syndrome. The best option here is the bolus of potassium, the phosphate, and potentially the MAG. So again, emphasize, I would not use the TPN for replacement for the reasons that we listed.
Can I ask a question?
Yes.
Back to the insulin, like, would you always add it to the TPN, or isn't it easier like to titrate if you add it separately to get it?
Yes.
Does that make sense?
I actually probably should have changed this since I'm giving the presentation. I typically prefer not to add TPN or insulin to the TPN for the reason you just described. Nurses like it a lot because if they're on an insulin drip, you have to do every 1 hour blood glucose checks. But if you put it in the TPN, it's essentially an insulin drip, right? It's just not titratable. So I think that's a very good question, and I agree completely. It's preferable, whether it's insulin drip or insulin bolus, to give it outside of the TPN so that you have better control of it. Answer your question? All right, so a little bit more complicated of a consideration is the carbohydrate fat lipid ratio. I gave you one potential reason for why it might be, and we discussed the triglycerides already. So the question is, should we change the carbohydrate lipid ratio to something that's a little bit more conventional, like 70-30? Should we adjust it, or should we leave it the same? Group 10, what do you think? Any thoughts from group 10 or any questions to clarify?
When we see that it is 60% dextrose, and normally it's 70-30, but we're not really sure if there's a reason why it should be different.
Okay. Would anyone like to jump in and add some thoughts to that? Anyone have a potential plan for this? All right, so let's start at 3. I'm hearing nothing. We've got 2 options, or really 3 options. Do nothing, increase the carbs, or increase the lipids. If we increase the lipids, we risk increasing the triglycerides, right? If we increase the carbs, we risk worsening the hyperglycemia. If we do nothing, we've already discussed triglycerides are likely to resolve because they're likely elevated due to starvation. And blood glucose is able to be resolved if we give insulin. It's not surprising that the patient should require insulin because the patient also has diabetes. So in this case, it is appropriate to leave the carbs and lipids the way they were. Likely the reason that they were started the way they were, and the explanation that I would give is the patient has a history of diabetes, so we want to increase the number of calories that are being administered via lipids, and decrease the number via carbs so that we can at least somewhat control the hyperglycemia. Does anyone have any questions regarding that or need any clarifications?
When do you expect the triglycerides to resolve?
Once the patient has been fed for at least a few days. So I would say minimum or maximum within 1 week, a hypertriglyceridemia should resolve. But it is likely going to be within about 3 to 5 days in a typical patient. I know that's kind of a vague answer, but a few days is a typical response. The reason that the triglycerides elevate with starvation, have y'all talked about DKA, any diabetic ketoacidosis? Okay, so it's a similar mechanism. Very different outcome, but similar. Your body does not have access to its normal source of calories, which would be glucose, to use as energy. It's starving. So it starts mobilizing fats, fatty acids, from its stores in order to have an alternative source of energy. So that's why triglycerides will elevate. Once your body is no longer in a starvation state, the triglycerides should be returned. Lipogenesis occurs, and it starts using carbohydrates and glucose as a source of energy again. So a few days process, but not a very prolonged process. Does anyone have any more questions on that? All right, and lastly, the patient's fluid status. What do you think about the fluid requirements based on ins and outs as compared with the amount of fluids that they're receiving? And what, if anything, would you like to do about it? Group 12.
So that almost a liter higher than the output, so we're thinking if we could increase the volume of the TPN, or if not, we could maybe use diuretic.
Okay. What does group 17 think?
It's over, right? Yeah, we said the same. So his output's a lot under the input. So we said we could like stop the normal saline thing since it's like 500
okay.
mils and decrease the volume of the TPN.
Okay. So I like the way you're thinking, and it is consistent with everything that we've said. However, remember, output does not account for insensible losses. We have no way of calculating the patient's insensible losses. And it's totally reasonable to think that a patient could have around a liter of insensible losses per day, particularly depending on their degree of illness. Like I said, if they're febrile, you look at that, their respiratory rate, are they on the ventilator, so on and so forth. So, if you want to assume that the patient does not have a liter of insensible losses, I think it would be totally reasonable to continue to monitor the ins and outs, continue to monitor their changes in weights, and to DC that abnormal saline. Diuresis is a good idea, but not necessary unless you think the patient has a specific indication for that. But when you evaluate the patient's weight, there's been little change up to this point. You can continue to monitor to see if it continues to trend up, and that would indicate that fluid is accumulating. But otherwise, I would say it is not necessary to make any changes at this time. Now, that is, again, based on clinical assessment, and it's something that you would have to trend. It's not something that you could just make a single glance and determine the answer. So does anyone have any questions about that?
So for the fluid status, like you were just mentioning, is there like a, I know you said it takes a few days to look at, so you measure it today and then like see if it's improving. Basically, if the input was, how much of an input would require an immediate change? If if any?
Again, so I know everyone hates this answer, but it always depends on the patient, right? So are they at risk for fluid overload? Do they have CHF? Do they have renal disease? Do they have edema present across, their entire body? With that consideration, I would say somewhere around 750 to a liter is a reasonable amount of insensible losses to expect in a patient. It is something that is much more easily measured with weight than it is just assumed in your calculations by looking at eyes and nose. And so the best and most appropriate way to do it, as long as there's no acute issue with their volume status, is to trend their weight over several days. If it stays approximately the same, then you know that you're good. If it is increasing every single day, you know you're accumulating fluid and you ought to do something about it. Does that answer your question?
Yeah, it does. Appreciate it.
Of course. Anyone else have any questions? Okay, does anyone have any questions about the cases or the material for Friday? What to expect for the test? Anything that we talked about today that you thought was confusing, that was unclear, that was not answered? Any questions at all? Okay, good. So on Friday, we will do fluid and electrolyte disorders. Once again, I will try to get the full slides posted for you so you can have them for your reference. But again, the material we went over today, which is posted, the material we will go over Friday before we do the cases is also posted, and that's the material that you need to know for the test. This is a lot of material. Even once it's been gleaned down, it's a lot of material, so it's important to know all of this for patient care, but the issue in front of you right now is the test. I understand that. So if you have any more questions about what you can focus on, please feel free to email me or ask on Friday. And if no one has anything else, then we are done for the day. So thank you all very much.